Hello, and thanks for the opportunity to give this presentation on cryoablation as a minimally invasive alternative to surgery for managing ductal carcinoma in situ, what I call the DCIS cryoablation trial. I'm Dennis Holmes. I'm the director of the Sam and Grace Carvajal Comprehensive Breast Center, CEO of Expert MD, and a longtime advocate for cryoablation. First of all, I want to apologize. I'm a bit under the weather, so you may hear an occasional coughing and not so quite clear sound of my voice, so apologies in advance. But why don't we get started? So let's first think about a little bit of background. Background regarding DCIS is that it's pretty well recognized that only a proportion, say 25 to 40% of patients with untreated DCIS will ultimately progress to invasive cancer. However, we're unable to reliably predict which DCIS patients will actually progress to invasive cancer. Therefore, the current standard of care is to recommend to nearly all women with DCIS the option of surgical resection in order to prevent the progression of DCIS to invasive cancer. Two-thirds of those women undergo lumpectomy plus minus radiotherapy. About one-third undergo unilateral or bilateral mastectomy with the goal of preventing invasive progression. If DCIS did not have the potential to progress to invasive cancer, there'd be no need to treat it at all. This natural history of DCIS speaks to the uncertainty about predicting how DCIS behaves, but clearly there's a large proportion of them that do not manifest as invasive cancer during the natural lifetime of a woman. And so there is an opportunity to really be much more selective, at least in theory, about how we manage DCIS based upon how it progresses. And in fact, there are a number of ongoing studies that are looking at the use of non-operative management of DCIS, ideally identifying patients who they predict to be low risk or intermediate risk and offering them an expected management solution or perhaps management with endocrine therapy alone as opposed to surgery. So clearly there's an audience for looking at less aggressive ways of managing DCIS. I'm one of the proponents of this. And of course, my approach to addressing DCIS is to consider the use of cryoablation as an alternative to surgery to prevent DCIS from progressing to invasive cancer and also eliminating the need to watch a condition that, potentially could progress to invasive cancer. So the rationale for considering cryoablation for DCIS is pretty much based on the idea that cryoablation works. It works for invasive cancer. We know that many patients with invasive cancer have coexisting DCIS, and the clinical trials of invasive cancer show that when we ablate the lesion, whether or not it has DCIS, and when we biopsy the areas, 6 months later or 3 months later or whenever, we almost never find any residual disease, either invasive or DCIS. So we know that cryoablation can work for DCIS. It's not an efficacy issue. Uh, thirdly, the treatment of DCIS, at least philosophically, should not be more aggressive than invasive cancer. We know that invasive cancer is life-threatening. We know that DCIS is not directly life-threatening. So why treat DCIS with the same level of aggression as we treat invasive cancer? A fourth point is that we know that DCIS can be killed by cryoablation. So it's not that DCIS is resistant to ablation. It's more that it's a localization problem. It's not a problem of, can it kill cancer? Can cryoablation kill cancer? It's more of a problem of how can you target cryoablation to DCIS to effectively kill it. And in fact, we deal with this issue all the time in surgery. We take patients with surgery with non-palpable, non-ultrasound visible DCIS, and we manage to effectively treat them with cryoablation with low re-excision rates because we can turn a non-palpable condition to at least a localizable condition with the use of some localizing device that helps us find it and helps us target during surgery. And so, we have already proven that we can localize DCIS. What we're considering in this trial is using cryoablation as opposed to surgery to address DCIS once it's localized. And lastly, there are some concerns about, the potential for multifocality and the risks of positive margins for treating DCIS because it's very hard to see. So with that backdrop, I launched a trial called cryoablation as a minimally invasive alternative to surgery for managing ductal carcinoma situ. This trial was originally actually named cryoablation as a minimally invasive alternative for preventing progression of invasive cancer, because ultimately the goal of this trial is to, offer patients an alternative surgery for managing DCIS so that the effective treatment of DCIS with cryoablation could prevent its progression to invasive cancer. In any case, you see the current title of the trial is as shown and as described. This was a single-arm pilot study. The goal was to enroll or is to enroll 30 patients. The primary objective of the study is to evaluate the ability of cryoablation to achieve complete ablation of DCIS within the cryoablation zone. Uh, and the study was limited to patients with DCIS measuring 2 centimeters or less by imaging. Secondary point of the trial was to evaluate the 5-year local recurrence rate of invasive cancer in the index quadrant. Again, we could certainly measure the recurrence of DCIS within the index quadrant, but again, the primary purpose of the trial is to prevent the DCIS from progressing to invasive cancer, and therefore the invasive cancer recurrence rate is the more important endpoint of the trial. Eligibility criteria for the trial included women age 18 and older with DCIS spanning 2 centimeters or less based on mammography, uh, ultrasound, and if performed, contrast breast MRI. The study was also restricted to women with DCIS diagnosed by minimally invasive biopsy, and it was not open to women with a prior history of ipsilateral DCIS or ipsilateral invasive breast cancer. All eligible candidates uh, were evaluated independently with an independent path review, independent imaging study review to make sure that both the imaging findings and the pathology findings were suitable for cryoablation and met study criteria of having a unifocal lesion that was histologically confirmed as DCIS and radiographically measuring 2 centimeters or less by imaging. Since it was expected that most patients would not have ultrasound visible DCIS period, the protocol allowed for the placement of an ultrasound visible marker prior to cryoablation, which could be used as a surrogate marker to target the ablation procedure. And so this was performed prior to ablation. And then patients subsequently underwent ultrasound guided cryoablation of the DCIS site. This image shows two examples of ultrasound visible markers that were used within the trial. The marker to the left is a marker that's composed of a basket made out of suture materials. It also contains a metallic component, but this suture component was visible by ultrasound, which you can see in this straw-like structure shown here, the front wall and the back wall. The other marker that we had available was a hydromark, which is a marker that is made of hydrogel with a metallic marker, and over a period of uh, days or weeks, the hydrogel hydrates and becomes more visible by ultrasound. This marker is immediately visible immediately after placement. This marker becomes more visible as over subsequent days, but either could be used for ultrasound guided localization. And in addition, we also use the localization wires for patients for whom we could not arrange placement of these ultrasound visible markers. All eligible subjects underwent ultrasound-guided cryoablation using a single cryoprobe. Uh, the goal ablation volume for the cryoablation procedure was an ablation zone of 4 by 3 by 3 centimeters on average. This is the volume that is achievable by most cryoprobes that are designed for treatment of breast lesions. It's very difficult for it to create an ablation zone quite significantly larger than this, but this is certainly an adequate enough cryoablation zone for a lesion that's 2 centimeters or smaller. It's important to note that We had to take into consideration the orientation of the microcalcifications, so that they were radially oriented or transversely oriented or oriented more in the anterior posterior direction. We had to orient the ice ball in order to optimize the surgical margins around the distribution of calcifications as they existed within the patient's breast. With the cryoablation procedure, we used what's called a double freeze approach, where each site was frozen twice. In general, there was a 10-minute freeze, followed by a 10-minute thaw, followed by a second 10-minute freeze. The probe stayed in position through both freeze and thaw cycles. In terms of study procedures, the study called for cryoablation of all patients, but the adjuvant therapy was elective and left to the discretion of the patient and the treating provider. Options included endocrine therapy, which was optional for patients with ER-positive disease, radiotherapy, which is also optional for patients. But we did offer patients genomic testing in order for them to assess their risk of local recurrence of both invasive cancer as well as DCIS. And based upon this, we wanted to enable them to provide more informed consent regarding their willingness to accept endocrine therapy or radiotherapy. Following cryoablation, post-treatment procedures included repeat breast imaging at 6 months post-ablation, and a stereotactic core biopsy of the cryoablation site, targeting either residual microcalcifications or the residual biopsy site marker. And the plan was for all patients to undergo annual follow-up if they were found to have no residual disease at the time of the 6-month post-cryoablation biopsy. So as I said, this study is ongoing with the goal of accruing a total of 30 patients in this pilot study. As of this week, we have enrolled a total of 26 patients, with 2 patients scheduled for later this month, and hopefully the remaining 2 patients to be accrued this summer. This is a list of the patients, and you see, in this table, their age, the maximum lesion size assessed by imaging. So the imaging study that showed the large dimension, that's what's listed in this column from actual imaging size, utilizing, information from mammogram, ultrasound, and MRI if performed. The estrogen receptor expression is shown in this column. The progesterone receptor expression is shown here. The nuclear grade is shown here, and then the diagnostic core biopsy results are shown here. What you see is the age of the population of 26 women was 65 years, the mean age. The mean size is 11.5 millimeters. You also have the receptor status summarized. 80% of the patients had hormone positive disease, and 20% of the patients, or 19% of the patients, had hormone receptor negative disease. Most of the tumors were low to intermediate grade, but as you see, 30% of them had high grade DCIS. Now, of those 26 patients, 18 of them surpassed the 6-month time point post-agression, and those 18 patients underwent stereotactic core biopsies of the cryoablation site, again targeting the residual microcalcifications or the residual biopsy site marker. And here you see the results of those biopsies. Of the 18 completed biopsies, 16 patients had negative results, primarily characterized by fat necrosis, chronic inflammation, and fibrosis. You see it as a consistent finding amongst all of the 16 patients that have had completed results with negative results. And there were 2 patients that actually had residual DCIS found. One of those patients is a patient who had a mistargeted lesion because the clip migrated away from the site of DCIS, and the DCIS lesion was incorrectly targeted because of this clip migration problem. And the second case was a patient who underwent an incorrect localization, meaning that there was a localization performed of a clip that was not at the site of DCIS. The wrong site was therefore ablated, And when the patient presented again 6 months later, she was found to have no evidence of ablation at the correct location, and that patient is actually scheduled to undergo a repeat ablation of the correct site uh, in the coming weeks. So, as I mentioned, in terms of outcomes, there were two missed lesions, both of which uh, was found to have residual DCIS at the time of the 6 month post cryoablation biopsy. There was also, amongst these 18 patients, a total of three local recurrences. All the recurrences occurred outside the cryoablation zone with no evidence of occurring within the cryoablation zone. These are the findings at a median of approximately 36 months. In terms of treatments rendered amongst these patients, uh, only 7% of the patients accepted radiotherapy, and only a third of the patients accepted endocrine therapy. It's clearly a group of patients that were disinclined to have conventional therapy, whether it was surgery or radiotherapy or endocrine therapy. And that's supported by the decision in most cases to uh, avoid radiotherapy as well as endocrine therapy. Some insights regarding the patients that experienced local recurrences. Here's one case where the patient underwent cryoablation of this area here, but was later found to have a cluster of calcifications that developed outside the cryoablation site about 9 millimeters away. And this was, in fact, the site of our local recurrence that underwent subsequent resection. Here's another patient who underwent cryoablation of a lesion here, and you see the markers that were placed before. This is actually a fibroadenoma that had been present in the past, an involuting fibroadenoma, but the cryoablation site was here and here, uh, and here and here. But you can appreciate perhaps some calcification that occurred again outside of the area of ablation, about 20 millimeters away. That was in fact an area of DCIS that was an indication of recurrence again outside of the cryoablation zone. Uh, and in retrospect, these calcifications were not seen on her pre-treatment studies. The same was true for the previous patients, that the calcifications that emerged post-ablation were not seen on the pre-ablation studies. Here's a case of the clip migration where the clip was placed at adjacent to, well, they intended to place a clip adjacent to a fairly superficial area of calcifications. The patient's nipple is here. This is the skin, and there's some calcifications here in the superficial breast. The patient underwent an original diagnostic core biopsy. They were able to have captured some of the calcifications, but when they place the localizing marker, it migrated from the side of the DCIS. When the patient presented for cryoablation, we made an attempt to place a second marker that we had intended to more accurately localize the lesion, but in fact, the second marker also migrated away from the uh, area of calcifications. Uh, I discussed with the patient the options for managing this, and we agreed that I would attempt kind of a triangulation to kind of triangulate the two markers with the nipple and hopefully align it appropriately to encompass the area of macrocalcifications. I proved to be inaccurate in that effort. I ablated an area that was adjacent to calcifications, but actually missed most of the calcifications in retrospect. And on a 6 month follow-up imaging studies, the calcifications were found to be at the edge of the coagulation zone. And the plan at that point was to manage it either with surgery or repeat ablation if that were possible, perhaps with localization with the wire. The patient has yet to undergo any additional therapy and is currently managing it expectantly. An additional point on the slide is just to note that if you're localizing DCIS for ablation, just as with surgery, you must recognize that clip migration is a common problem. Perhaps as many as 20% of cases have migration of the clip at least a centimeter away from its targeted area. And surgeons are fairly used to making adjustments to accommodate for this migration. It's something to consider when we do surgery. It's also something to consider when we do cryoablation. And certainly I tried to make that adjustment in this case, but it was unsuccessful. So in conclusion, I would like to say, based upon the interim results of the study, that cryoablation uh, did achieve ablation in 16 out of 18 cases enrolled so far, with it successful in 16 out of 16 cases that were accurately targeted at achieving complete ablation of the residual DCIS, as evidenced by biopsies performed in these patients 6 months post-ablation. Uh, the obvious failures had to do with inaccurate targeting, as I mentioned, which stresses the importance of accurate localization. But the preliminary results show that cryoablation to be an effective solution for selected patients with DCIS. And I hope that the findings of this trial begin to move the needle forward and expand the inclusion criteria, not to just older patients with ultrasound-visible invasive cancer, but to patients of various ages who present with DCIS, who are considering a non-surgical approach for managing their DCIS. Cryoablation does appear to be at least a reasonable consideration, and we hope that this trial will ultimately prove that. Uh, it's important to note that this is a single center study. We plan to follow the patients for a median of 5 years. Stay tuned for additional results as we both conclude the study, as well as present the long-term results as they emerge. Thank you very much.